Good morning. I'd like to call the meeting to order. This is a meeting of the Health and Human Services Finance and Policy Committee. It is Wednesday, February 25th, and we do have a quorum present. Today we have presentations by the three different agencies, and then we have an update from Hennepin County. Our first presentation is from MNsure and the Minnesota Department of Commerce. And we have, welcome to the committee, we have Erica Helvig Anderson, Senior Director of Public Affairs from MNsure, and Julia Dreyer, Deputy Commissioner of Insurance at the Department of Commerce. And when you get your presentation up, then we can begin.
All right. I think we're good to go.
Ms. Dreyer, if you could state your name for the record, absolutely. And you can begin.
Good morning. Thank you for having me here today. My name is Julia Dreyer. I'm the Deputy Commissioner of Insurance for the Department of Commerce, and I'm joined here by my colleague, Erica Helvig Anderson, the Senior Director of Public Affairs at MNsure. So I'll be touching on what Commerce is currently observing in the commercial insurance market more broadly, and Erica will be sharing some information on MNsure's most recent open enrollment. If you want to go to the next slide. Just to level set, most Minnesotans continue to get their insurance either through their employers or from government programs such as Medicare or Medicaid, which we refer to as medical assistance here in Minnesota. So what we regulate at Commerce, the individual market and the small group market, is just a tiny part of that overall pie. It's down there in the bottom in light green. But still an important component of how many Minnesotans access their insurance. The state also obviously has some jurisdiction over medical assistance and Minnesota Care, and the federal government oversees most large group plans as well as Medicare. While each of these component parts of the health insurance ecosystem have their own rules governing how they function, they also are increasingly interdependent on one another. So changes in one space frequently have an impact in other parts of the market. We know that health insurance is expensive, and what we're seeing in terms of cost increases in health insurance is largely driven by what it costs to provide that care. So just briefly, some changes that we're seeing. There are changes in medical technology and treatments, so that's things like specialty drugs for rare and genetic diseases, which are life-saving in many cases, but also very expensive. Cancer treatments are increasingly personalized, and then we have things like weight loss drugs, like GLP-1s that are popular and also pricey. We also know that people are sicker and using more healthcare services, so the population is in general aging, and Minnesota's individual market in particular trends a little bit older, so we're seeing some increased costs there as well. And then finally, contracting with providers is more expensive, so we're seeing consolidation, things like increased staffing costs, and then just inflation. Within the individual market segments, there are certainly different or unique trends in each of those that we're seeing. So for example, in the Medicare market, again, there's impacts on the aging population. The Medicaid market's continuing to fluctuate following the expiration of the public health emergency with new enrollment and with projected new enrollment restrictions. Enrollment in the small group market is continuing to decline, so we're seeing some healthier small groups choosing to self-fund, leaving the remaining pool sicker and more expensive. And then obviously, which we'll get into more in the presentation, the elimination of the enhanced premium tax credits is increasing the risk of healthier people leaving the individual market and driving up costs. As I just mentioned, the federal government is continuing to make some policy changes throughout the healthcare system, both legislatively as well as through executive agency actions such as rulemaking. So this year in particular, we're seeing the elimination of the enhanced premium tax credit. So Congress hasn't passed funding to allow for the continuation of that credit. Under the Affordable Care Act, tax credits had capped what people making under 400% of the federal poverty limit, so that's around $60,000 a year, what those people paid in premiums, so capped it at 8.5% of their annual, roughly 8.5% of their annual income. During the public health emergency, Congress extended this to ensure that no one buying insurance on their own would pay more than 8.5% of their income on premiums. So this change through the elimination of the tax credit primarily impacts people over 400% of that federal poverty limit, though those at lower income levels are also impacted. The average household has seen an increase of almost $3,000 a year this year. And then the expectation is that those who are healthier may choose to forego insurance, particularly over time, leading to a sicker and more expensive pool of people. There have also been a variety of changes that the federal government has proposed that make it harder for people to enroll in coverage. So human nature being what it is, those who need coverage the most also tend to be the most motivated to go through the enrollment process. So federal changes impact how MNsure can auto-enroll people in coverage, restrict the state's ability to set annual and special open enrollment periods, and adds additional red tape to certain eligibility requirements. Federal changes are also impacting what people are able to purchase. So for example, all bronze plans are now considered to be high deductible health plans and are eligible to be paired with health savings accounts. The federal government also continues to make and propose other regulatory changes. We just had a rule that came out earlier this month that we're still working through, which shift policies and can further impact Minnesota's commercial health insurance market. So each year, Commerce looks at proposed rates that insurance companies are intending to submit. We don't set those rates. Again, we just review what companies intend to offer, and those rates must be approved before the plans can be sold to Minnesota consumers. Rates have to be justified both by the benefits that the consumers receive for their premiums and by the insurance company's ability to pay expected medical claims. Excuse me. The final average rate increase for plan year 26 for the individual market, so this is the plans that are sold on MNsure, was 21.5%. And then if you want to switch to the next slide. And then in the small group market, it was 14.2% this year. The increases that we're seeing in both markets are predominantly driven by increases in healthcare costs. And we get a lot of questions around state benefit mandates and the impact that that's having. Well, they certainly have a cost impact, particularly in the small group market where any of those additional costs aren't defrayed. It's really not the driving factor in the rate increases we're seeing. Again, it's really due to increased medical costs and then a lot of the other changes we're seeing in the federal government. Additionally, the state does have what we call the premium security plan or reinsurance. Typically, we see around rates are typically around 20% lower because of the program. This year, those rates were 47% lower, in large part because of some of the changes that the federal government was making. So we saw a significant increase or significant impact because of that program this year. This year, the reinsurance program is funded through a state appropriation. Next year, it switches over to an assessment on group health insurance companies. And after that, the program has expired unless we seek approval for extension of the waiver. I'll turn it over to my colleague, Erica.
Welcome to the committee. If you can state your name for the record and you can begin.
Thank you. My name is Erica Helvig Anderson, and I'm Senior Director of Public Affairs at MNsure. Thank you for having me here today. I will have three main parts to my presentation. First, I'll walk through the impacts of HR 1 and lay it out as a timeline. Second, we will walk through open enrollment and impacts we saw there. And third, we'll talk about the operational impacts of enrollment head on MNsure. So you can see on the slide, the impacts of HR 1 is phased in over multiple years. So this year we saw the end of the DACA recipients eligibility, the increase of out-of-pocket maximum for enrollees, and the end of enhanced premium tax credit that were sunsetted at the same time HR 1 was passing. Cuts to MNsure open enrollment period, shortening it will begin next year. That will have some impact on our what people have been accustomed to, so we are unsure what behavior will be driven by that, but we also do know that historically, our younger enrollees happen to come in towards the end of that, so we'll be doing outreach to see what we can do about that, but that is a natural consequence we're seeing there. Limited tax creditable eligibility for immigrants will also be starting, and then the year after that, will end the automatic re-enrollment for MNsure enrollees. I'm going to talk a little bit about some examples about the premium increases. In 2025, a family of 4 living in Albert Lee, earning about $105,000 a year, paid $143 per month after the APTC for their bronze plan. In 2026, they will pay $490 per month for the same plan. That's a 243% increase. In 2025, a 40-year-old married couple living in Marshall County, earning $69,000 a year, paid $423 per month after the APTC for their silver plan. In 2026, they will pay $725 per month for the same plan. That is a 71% increase. So those are some, while we usually say averages, I wanted to give some examples of how those, depending on your location and your age, how those averages will actually impact you. For consumers with annual incomes above 400% of the federal poverty levels, they have no access to APTC. So examples for them are even more extreme. A married couple in their 60s in Mankato earning $89,000 a year saw their net premiums increase from $500 per month to $2,000 a month. That's a 322% increase. A married couple in their 60s in Bemidji, earning $85,000 a year, saw their net premiums increase from under $500 per month to $1,700 per month in 2026, a 265% increase. So those are the impacts that that people felt as they were shopping, just to have a setup of what our open enrollment looked like. For open enrollment this year, we saw signups that were lower, signups of 162,000, which is roughly 3% lower than last year. Signups don't tell the whole story. Signups include our new consumers and passive enrollees, but it does not remove our cancellations. What changed because of enhanced tax credits ending is, so we also saw in this the active enrollees, which is our 8% of enrollees. 8% of enrollees dropped and did not choose to keep their insurance going into the next year. So we saw an 8% decrease. And then on top of that, we saw a January effectuated enrollments. So that's a 6% decrease from the year prior. That's how many actually made that first month payment. So you can see on the chart, while our signups were at 162,000, and then when we had lost 139,000, we lost down to 139,000 who actually enrolled, and then then we went down to 122,000 that had their effectuated coverage. And you can see those percentage changes from the year prior. So we did see fall off from, we're assuming the effects of costs. We also saw new consumers coming to MNsure, dropping by 40%. So nearly 18,000 fewer new people came to MNsure this year. Household eligibility for the tax credit fell from 61% last year to only 50% qualified for the APTC this year. One way to look at the cancellations and terminations is we had an increase of 47% of those who were auto-enrolled who chose not to continue their insurance with MNsure. About 15% of enrollees canceled during the open enrollment period. That's up from the 10% the year before. These are early numbers, but the trend is clear. We're seeing real consequences at each stage of enrolling in MNsure, shopping and comparing plans, signing up for a plan, and then making that first month payment. What we also saw is that Minnesota's tried hard to stay covered. We saw Minnesotans switching plans at an increased rate of 87%. Normal human behavior is they auto-enroll into a plan and they just continue on with that plan if it worked from the year prior. But we saw people come in and shop and compare and find a plan that works for them that might be at a lower rate. Over 80% of those who switched plans chose a lower premium plan. About 52% stayed within the same metal level. So they were able to find a less expensive plan, a lower premium plan at the same metal level that they currently went. So if they were at silver, they stayed in silver. If they're at gold, they stayed in gold. However, we did see a 112% increase in consumers buying down to lower metal levels. So we're seeing consumers actively managing affordability. Early analysis of the demographics show that older enrollees, using that as age 55 plus, made the most changes. 21% changed plans. 80% of enrollees who changed were able to find a lower premium. However, we also saw with younger enrollees had the highest rate of disenrollments who left MNsure. We are watching this closely and communicating with our colleagues at other agencies since it affects the overall health and stability of the individual markets when we see the younger folks exiting the market. Despite these figures, some things were made very apparent. Minnesotans care about their health and they care about the health of their families. They want to be covered and to protect themselves financially if a major health issue should arise. As a result, MNsure saw a record-breaking activity through our helplines and our partners, our assisters and navigator partners. Our website had an increase at record levels. Website traffic was higher than ever, specifically in the areas where you would find help with like a broker or a navigator, or where you shopped and compared. Calls and appointments for brokers and navigators had increased. Minnesotans wanted to stay covered. They just needed coverage to be affordable. We also saw just record levels at our contact center as well. We expect, looking forward, we expect continued enrollment volatility this year as well. Open enrollment, I just wanted to point out a few other things. We saw a 30% increase in our call volume, which was really large for MNsure to absorb, but we were very proud of the work we did. Across all lines, we saw a 23% increase, 29% increase from last year, and that's roughly 60,000 higher than the 2 years prior. Main lines were nearly double what we saw 2 years ago. One feature that we have added is a courtesy callback number that has helped. It's a modernization that has helped with this. We saw a 98% completion of those who, an increase of 72% of those who wanted to use the feature. And then of those who chose to use the feature, we got a 98% completion when we connected for our callback. This reflects a contact team that stepped up under real pressure. At the end of these days, these numbers represent families making tough choices. We saw record engagement because Minnesotans value health coverage. They shopped, they compared, they tried to make it work. But affordability determines whether coverage is sustainable for a lot of Minnesotans. Our team managed unprecedented demand and improved performance under pressure. We remain focused on our mission, ensuring Minnesotans have access to affordable health coverage. Thank you.
Just to conclude, I think both of our agencies, as well as the other healthcare agencies, are continuing to evaluate what all these federal changes mean for Minnesota's insurance markets. And again, as I pointed out, there are still some ongoing changes in both the Medicaid and Medicare markets that are also continuing to have ripple effects in the markets that we oversee here in the state. And we will continue to seek opportunities that provide temporary relief for Minnesotans and also provide longer-term stability for the overall market. Thank you.
Thank you. Members, do you have questions? Senator Edke.
Thank you, Madam Chair. And first one is a comment. As I look at everything in the presentation and we talk about the various items that drive up the cost of health care and health, in this case, health insurance, nothing's mentioned about legislative actions over the last 3 years that have added a lot to that bottom line also. Do you guys do you have anything that shows us that? I know that, you know, on the health insurance side, they talk about $30 per member per month increase in costs because of mandates, and we know there's a lot of taxes and fees. Do you break that out and make that part of your presentation too, so we can see the full effect? I see a lot of things here talking about federal changes, but we have a lot of Minnesota changes that affect these too.
Ms. Dreyer?
Chair Wicklund, Senator, that's a great question. I would certainly encourage you to ask the health plans for a breakdown of how they've calculated all those costs. Again, when we're looking at rates, we're looking at some overall trends within the market.
Senator Edke?
Thank you, Madam Chair. Well, the Department of Commerce works those numbers too, so I would think you guys would have a handle on it. But the other question I have, because we're talking about MNsure, MNsure is just an exchange, correct?
Correct.
Okay. What is the reason for the $30+ million reserves when you're just an exchange? What is the purpose of that excess money?
Ms. Helvig-Anderson? Or Anderson-Helvig, sorry. Or Helvig-Anderson, I got it right the first time. Sorry.
Madam Chair, members of committee, right now, that reserve, that's our bottom line, also reflects some costs we have incurred, but we've not spent on some of our modernization projects. So I could get you a more detailed breakdown of what actually is reserves and what is dollars that we have incurring the cost, but the project hasn't ended, so we haven't had to complete payments.
Senator Edke?
Thank you, Madam Chair. Yeah, that's why I asked the question. I mean, when we look at the numbers for insurance companies, they have reserves because they have to pay claims, but you don't pay claims, so.
Understood.
But I understand what you're doing, so thank you.
Yep.
Senator Mann?
Thank you, Madam Chair. I think we have to just kind of point out, there's always this question about insurance mandates when we talk about the rising cost of health insurance. And in Minnesota, we said that when you pay for your health insurance, you have to get health care. Like that's the point that we're trying to make. And to say that to tell health insurance companies to cover health care is what's driving the cost is absurd, right? For example, we mandated hair prosthetics for people who are losing their hair after cancer treatment, which added 13 cents to health insurance premiums. Whereas the cuts from the federal government added to one family $1,500 in a month. So let's not sit here and compare apples to oranges. And that also makes me realize how there's just a lack of understanding of how health insurance works in this committee, and I am more than happy to pull anybody aside after committee to talk about it if you feel that that would be helpful. And then just to kind of reiterate what the federal government did, they took away health insurance from DACA recipients who by all means are Americans. They've been here their entire lives. Many of them only speak English. They do not know another country. We took away their health care. We ended the out-of-pocket maximum limit for enrollees, saying that, you know what, you're not paying enough, so we're gonna make you pay more, as if it's not expensive already. Then we, of course, ended the enhanced premium tax credits, increasing some health insurance for families by $1,500 per month. We cut the annual enrollment period so that we were making sure that people don't have a chance to get health insurance. And then we ended the automatic enrollment, again, to make sure that people don't even get health insurance. So I am dying to hear the solution to what we're going to do to all the people in the state who no longer have health insurance. Do we just let them die? Is that the solution? I'm just wondering, because no one else, because people seem to be okay with what's happening here, but not offering any actual solutions to the gigantic problem that the federal government is causing the state. Thank you.
Senator Abler?
We could discuss this for an hour, and I'm not going to do that probably, but I appreciate actually I agree with both of my colleagues. And I think we should pay for, wigs for people, and I've supported pretty much every mandate ever because insurance should be worth something. But we have done all kinds of things to subsidize the cost of care, which is what the Affordable Care Act did. And back then, you weren't here, but I said it's not going to work. And we've spent probably $1 trillion or something like that subsidizing the cost of care while we've done nothing to handle the cost of care. And I will join with you, Senator Mann, that it's the middle people who are doing that. The PBMs, the brokers, not necessarily the agents, they don't get very much, but there's all kinds of fingers in the middle. The people that review claims. I joined the picketers at Alina at Unity, and the doctors there, they were charging, it was a $200 charge, they got like $35 out of it. So it's not even going to the clinicians. And and the whole ACA, it's how shall we subsidize it? And the feds are $38 trillion in debt, which for me is a lot of money. Anyway, so let's figure out a way to take away the money from the people who are providing nothing to the system. That's my idea. And anyway, so that's my short version, Madam Chair. Thank you.
All right, thank you. Any other questions? I just wanted to ask a couple of things. Senator Mann alluded to it, but I just wondered if you could, on the page that you talk about the overview of federal changes, what is the maximum open enrollment period that we will be allowed to have? And then what is the current one? Can you tell us that?
Yeah, I believe it's December 31st going forward, and right now we have January 15th.
Okay. So the starting date will be the same in November?
Yes.
Okay. And then can you talk a little more about the ending of automatic re-enrollment and how you think that might, be projected to affect Minnesota?
Yeah, we feel like that will have a large effect on Minnesotans. Right now, we are able to auto-enroll them into, crosswalk them into, maybe Julie can speak a little bit more, but like the same or similar plan that they currently are in, and then they can review, which just takes a lot of burden off of Minnesotans coming in and making sure they hit all of their finalized. So we can do that all on the back end, make sure they still qualify, and make sure that they're crosswalked into the same or similar plan. And that adding that, we know that anytime you take extra steps to do something, those who need the health insurance are going to make sure they go through all the steps, and those potentially who are less in need of health insurance might not make it through all the steps, and that could then impact our larger market.
And do you have an estimate of how many people today are kind of participating in that manner?
Overwhelmingly, the majority of our enrollees come through in that manner.
And so, just so I understand then, when this goes into effect, we'll have to actually undo the things that we've put in place to make it
Easier.
a more streamlined, easier process, and people will have to take more steps and, go through more steps to get their insurance.
Madam Chair, yeah, correct. They'll have to go in, do the re-enrollment, and not have that courtesy cross-enrollment from being a prior enrollee that we already know that's out there.
And I imagine that when we get to that point, that there will be a cost for doing that work, because we'll have to take our systems and move them from what they do today to what's required. Then I just had a question on the slide about the early analysis. We talk about consumers sought cheaper options, and you said there was a 112% increase in consumers buying down. Can you talk a little bit more about, what the impact is on consumers, like their everyday lives, because they're choosing to buy down?
Yeah, and I wanted to be clear. So they're buying down to lower cost premiums, but not necessarily lower cost out of pocket. And I think that's maybe what you're referring to. So they might have be able to make their, the first step in insurance is, can you make your premiums, your monthly payments? And then the next step is affording their out-of-pocket costs. So when they're buying down, the different metal levels, the ratio of that out-of-pocket cost shifts, and they have more out-of-pocket costs and a lower premium.
Okay. So again, for value for consumers, there's not an improvement in value for them. They're doing it because they can't afford.
So their premium, Madam Chair, their premium would be lower, but potentially more co-pays, higher deductibles. How about overall out-of-pocket costs?
Okay. Thank you. And then I wonder if there was any other, I think those were the main questions I had. I just want to echo what Senator Mann said. I think overall this is not, it's not a good prognosis for our individual market. These actions are going to, weaken our individual market. Fewer of the healthy people will choose to stay in it. And I think, we're seeing early analysis of what's happening this year, but that will continue to, the negative effects could continue to increase on our individual market as these other items that you said are federal changes take effect. And overall, this market serves a really important purpose right now. I mean, I am supportive of reforming our healthcare system, but the market right now serves a really important purpose, and there are people who depend on this for access to health insurance. And it just seems like the deterioration of this market is really going to have a harsh impact on many Minnesotans in areas like farmers and people who are close to retirement, and that's just not a good thing for the state. It's not going to be helpful for our economy. So thank you very much for your presentation. Are there any final questions? Okay, not seeing any. Thank you very much. Next, we're going to move to presentation by the Department of Health. And welcome to the committee. And first, we will have a presentation about update on impacts from federal actions. And we have Deputy Commissioner Wendy Underwood here. And I'll let you get your presentation up.
Great. Thank you so much.
Welcome to the committee, and please state your name for the record, and you can begin.
Great. Thank you, Madam Chair and members. For the record, I am Wendy Underwood, Deputy Commissioner for the Department of Health. Appreciate being with you today. We'll just give this a second for the presentation to come up online. Maybe it's this one. Okay. You all heard last week from State Budget Director Anna Mingi about the most recent efforts by the CDC to cut our funding at the Department of Health. On February 12th, the Center for Disease Control and Prevention confirmed that they were canceling about $38 million in public health investments for Minnesota, effective as of February 11th. This is the remaining amount of a $65 million 5-year grant known as the Public Health Infrastructure Grant, or FIG, which is funding meant to support critical public health infrastructure needs so we are better prepared for future health threats. The funding was established in 2022 with an end date of November 2027, so almost 2 years from now. Funds were received originally by 107 health departments across the country in all 50 states, but the cuts announced earlier this month were to only 4 states: Minnesota, Colorado, California, and Illinois. Now, according to the CDC, FIG is, quote, groundbreaking investment supporting critical public health infrastructure needs across the United States to create a stronger, more resilient public health system that is ready to face future health threats. The funding is flexible with the intent of allowing for public health decision-making at the state and local level to focus on structural, organizational, and community needs. The CDC's stated reason for terminating our grant was, quote, inconsistent with agency priorities. Yet the CDC priorities statement specifically calls out modernizing public health infrastructure while enhancing our approach to health data. And I'll share with you how these funds have been used. We have not received any further details yet, and frankly feel there was no need or valid justification for these targeted cuts that put Minnesotans at risk. All of these actions further erode Minnesota's ability to prevent and respond to myriad public health challenges. So I want to talk about what these funds do and the impact of these cuts. In Minnesota, and as intended by the initial award, these funds have been used to support critical public health infrastructure needs. This work was happening within MDH as well as across all local public health and tribal public health departments. The funds are being used to strengthen Minnesota's emergency planning and response work, to modernize our data systems, to grow the public health workforce, to build public health services at the local level and tribal communities, especially in greater Minnesota, to enhance efficiencies and effectiveness of public health programs, and much more. And as you've heard countless times from Commissioner Cunningham and others, public health has been underfunded for decades, despite us fighting for more support. And we saw the implications of an underfunded system during the COVID-19 pandemic. These funds were meant to start filling in those gaps. We know from COVID that there is no time to learn how to respond to a crisis. You have to already know what to do and have plans in place so that you can act as quickly and as smart as possible. That was a major purpose of this funding. Now, Attorney General Ellison joined attorneys general from the other targeted states in filing a lawsuit, and late on February 12th, the judge granted a temporary restraining order, which is in effect until March 12th, while there are additional legal proceedings, including disclosure of the termination justification by the federal government. And while this is a critical step in the legal process, there are a lot more steps to come, and we remain very vulnerable. You may recall that I was with you right here nearly a year ago when we had our first significant blow from the federal government with the overnight cancellation of over $200 million in grants that were issued also during the COVID pandemic. And this was a huge blow felt nationwide. Ultimately, a multi-state court case was successful in helping to restore access to those funds through an injunction. But that wasn't before we had to take steps to pause vital public health work. We lost critical time, knowledge, resources because of all of this. I always think it's really important to put practical experiences to what we're talking about. And so I want to just speak to how these funding cuts impact our ability to modernize and maintain key data systems, slowing down MDH's ability to detect health threats, respond to outbreaks, and make timely decisions. For example, important infectious disease laboratory testing work requires a robust laboratory information management system to track, test, and rapidly report results that guide patient care and outbreak response. The system I'm talking about in Minnesota and at our public health lab tracks concerns ranging from food poisoning to measles. The current system is old and cannot meet the demands of a modern integrated public health laboratory, making FIG funding essential to implement a new system. And we've been using the FIG funds as intended for just this purpose, with work on this system scheduled to be done in April 2027. The project is now in jeopardy. These funds also help us to protect, maintain, and improve health by supporting a strong public health workforce, which FIG has been instrumental in doing, particularly in greater Minnesota. FIG funding has also supported critical emergency planning, communications, and response, again, particularly at the local level. Loss of funding could reduce the state's ability to quickly mobilize trained staff during public health emergencies, keep pandemic and other emergency plans up to date, and provide timely, reliable data to inform decisions. This funding is not only helping just build these things, but train and establish long-term capacity to support this work well into the future past the intended date of these dollars. And then just quickly, some examples by the numbers. This termination eliminates nearly $8 million to counties and nearly $1 million to tribes to improve public health response systems like access to data, communication, emergency response plans, and training, like I've mentioned. It eliminates over $5 million in contracts to develop and complete the modernization of data systems and other needs, which has a real economic impact on our partners. And the local public health investments have especially key in greater Minnesota, where these cuts have a disproportionate impact. As we all know, small counties have few staff who wear many, many hats. These funds have been helping build updated public health systems that support rural counties and their unique needs. So I'll just wrap up by saying that these sudden funding cuts we've seen and experienced and really felt over the last year, and suggestions of more to come, cause unneeded confusion and chaos. They affect us at the state level, they affect our partners at the local public health and tribal public health levels, our community organizations, and most importantly, they put the people of Minnesota at risk. I'll also note that responding to these funding cuts takes our attention away from being able to do what we need to be doing, which is to protect, maintain, and improve the health of Minnesotans.
Thank you. Members, do you have any questions about this part of the presentation? Senator Abler.
Well, I'm really disappointed at the actions of the feds. This last year, I think they cut some grants on Tuesday, effective Monday.
Right.
But I was also I thought that was not a good thing. I also with all respect to some of the choices the department made about who they're going to lay off. They got rid of the tuberculosis worker, and just to me, it seems like there's some choices that you all can make there that would focus. And just to encourage you, in the world of challenging budgets, in 2003, I should have copyrighted my thing, but essential, important, and nice. This committee in 23 spent a ton of money, so did the Human Services Committee. And we'll talk about hospitals later, but we didn't take care of those, but we funded some programs that are, little nice programs that upon further review, you'd rather have the hospital open. And so as you go into this, I encourage you all to not be afraid to say, this is not as important, and try to keep the politics out of it. But I think this is, I think I used the word ridiculous yesterday. I'm going to use it again today. This is not a good way to govern. And Senator Mann, if you and I want to put a letter together, it seems to me, and others, at some point, somebody has to work together. We have 8 Congress people and 2 senators, and I don't think they talk very much about anything. But it seems to me if we could somehow cajole the Republican congressman to talk to the Democratic Congress people, men, whatever the role title is, this would be something like a white hat thing. Could you please protect Minnesota's infrastructure? And it might just catch on. And so I'm willing to do that. At some point, you don't have to be, clearly they don't understand the value of this. And, we can lawsuit after lawsuit, and now, Keith has a lawsuit, and this one has a lawsuit. And you can't govern by lawsuits. I think that one role we can have is a voice, and I don't know who all would sign such a letter, but I would. If it's just kind of a nice letter saying, please don't do this, it's not a good idea. And I think that's something we should just think about. So anyway, thanks.
Senator Mann.
Thank you, Madam Chair. Thank you, Commissioner, for your presentation. You talked about the impact on our public health with all of these cuts. But I was wondering if you could go into just a little bit more detail. I know that we eliminated the norovirus and food safety program, as well as STD detection programs, and we eliminated 2 field epidemiologists in Greater Minnesota. Can you talk about the impact of eliminating those programs and what will that do to people?
Sure.
Ms. Underwood?
Thank you, Madam Chair and Senator. And I assume, you're referring to the cuts we were navigating last year? Because interestingly enough, we are anticipating potentially more cuts to our federal funding for STI and HIV surveillance and response. Yeah. So preparing contingency plans should that come to pass, and happy to come back and talk about that some more. But to your question, and to Senator Abler's comment, and Senator Abler, you did such a letter last year in response to this first round of $200 million in cuts, and we were very, very grateful for that, and appreciate your continued advocacy, and to your point about how this is not a way to govern. And we have come here to share with you these significant reductions that have led to court injunctions and other legal activities. We have not come before you when we've experienced what I call the blips. When a staff member shows up at work in the morning with a notice that the grant they manage from the federal government has been rescinded a day before, and by the end of the day, it's restored again. That's happened a few times just in the last few months that I can remember. And it's very sad to have developed a muscle memory of how to prepare and respond in preparation for these potential cuts. It's not what we thought we would be doing, but we do have a strong system in place for developing contingency plans and identifying critical priorities to continue forward with the vulnerability of these dollars. Specifically to your question, Senator, and particularly raising the elimination of the Greater Minnesota Regional Field Epidemiologists, was incredibly challenging. The way that those positions were supported with the $200 million and us facing significant layoffs at the agency, we have processes in place, through with our bargaining units and other things that we have to do some actions with temporary positions, which those were at the time. We've since worked hard to restore that work. Once we were able to get that funding into a preliminary injunction, have worked hard to at least be able to pick up the responsibilities in other ways. But I mentioned, with our small counties, our rural counties, wear many, many hats. And so for us to be able to provide that critical on-the-ground support in responding to diseases and all the things that epidemiologists are so skilled at is very challenging for us and very detrimental to those counties that they are serving. So we've been doing our best to balance and wade through.
Madam Chair, members of the committee, if I may.
Ms. Timian, just state your name for the record,
Lisa
please. Timian,
Timian, Director of Government Relations for the Department of Health. To Senator Abler's point, it's also challenging because historically the health department's about 50% federally funded, which means about 50% of our work we're not regularly talking about with you all because it doesn't come from state funding for that, right? So a lot of these things that we would have considered just core public health, that's just standard, and it comes from money from the federal government, we're not really explaining to you all how important that is to our core mission, even though it is, because we don't need to ask you for that money. So I've realized that that is a weakness of our explanations to you all, and that you're not always seeing the full picture of everything that we're doing to protect, maintain, and improve the health of Minnesotans. So that's something we're working on for education purposes for you all.
Thank you. And I guess, just to add on to that, there are many funding streams that go directly to the local public health and community health boards.
Yeah.
They have extremely fragmented funding, and they're very vulnerable to interruptions in those fragmented funding streams. They try to cover, dozens of responsibilities, but some of the restrictions on how they use the money are really, are problematic to just getting all of the work done. And I think the cuts that we're seeing, you know, have a really serious impact on them as well. So just want to point that out. Senator Bolden.
Thank you, Madam Chair, and thank you for this presentation. I do appreciate your last comment, and I think at the right point, having a broader picture of all the work that you do would be useful and important. You alluded to this a little bit, but I'm going to touch on actually the last bullet point that you mentioned here about how all of these funding cuts is also, you know, outside of the direct impacts of the funding cuts, it also is taken away from all of the other work that you are doing. And, you know, you talked about the worker who comes in the morning and sees, oh, the grant that I'm working on has now been rescinded. Has it? Hasn't it? You know, we're getting sort of edicts by tweet with no details. Things are on and off, and I just wonder how much the chaos and the confusion. I wonder if you could say a little bit more about the impacts that has, like the time, resource, and energies that you're putting into that. What does that mean, and how is that affecting your greater mission and all of the other work that should be happening?
Yeah.
Ms. Underwood.
Thank you, Madam Chair and Senator. I appreciate the question. I feel like I live your question, especially since the last time I testified was on this exact thing, you know, a year ago, and have been focused on this work ever since. You know, we are incredibly fortunate to have a committed team who chooses public health and who chooses to be at the Department of Health, and we have an incredible relationship and connection with our community health boards and our tribal public health leaders to be able to hang on. But we do worry about toxic resilience, you know, and I mean the burnout and the stress of understanding what is happening is very real. And so we are leaning in and putting in the extra time and effort to ensure that that what we want to be doing and what we are responsible for is happening, but it is happening more and more stretched all the time.
Senator Boland.
I'll just thank you for that. I'll just say, you know, we know that public health is one of those things when it all goes well, it just kind of runs in the background and
Exactly.
the public doesn't usually, you know, think much about it until things don't go well, and then it's a crisis. And so the work that you all do is really, really important. And so thank you for doing that and being here and helping us understand better how it's being affected.
Thank you.
Seeing no other questions, I thank you very much for this part of the presentation. I really appreciate your bringing the information forward, and please continue to let us know as things come up that we should be aware of. So thank you.
Thank you so much.
And now we're going to move to a presentation about the Rural Health Transformation Program. And we have two presenters, Diane Rydrick and Zora Wadosovic. Sorry. And members, we will want to move to the presentation by Hennepin County Medical Center so that we allow enough time for discussion about that topic as well. And I think some of the information you're covering, if people have questions about details, you know, please go through your presentation, but there might be more details that people have questions about that they can take offline to the department. Ms. Rydrick, are you beginning? And please state your name for the record and you can begin.
Yeah, thank you, Madam Chair. For the record, my name is Diane Rydrick. I'm the Director of the Health Policy Division at the Minnesota Department of Health, and we are very pleased to be here today to talk about the Rural Health Transformation Program. I'll just note at the outset there are a lot of slides here, and we are going to skip the first few, which Ms. Timian is advancing through. We do a rural health chart book every year or two we update, and it's just a lot of data that we aggregate on access to health care, use of telehealth, workforce shortages, et cetera, in rural areas. And it's really important foundational data that helped us develop this program, but you have it, and you can look at it. And I think just in the interest of time, we're going to jump right into the grant components of it. But we're happy to take questions now or afterwards about any of the slides that we went through. So we will start midway through, and Lisa, if you could advance to the next slide. Thank you. Just a note, grants, federal grants, as Deputy Commissioner Underwood just pointed out, are living things. And so what we will talk about today is what we submitted to CMS and what was approved. But just know this is a 5-year grant, and it's possible things will change at some point in the out years based on CMS priorities changing or based on future year funding. But we're laying out what the vision is for the grant for the whole 5 years. Next slide. So you all certainly recall the Rural Health Transformation Program was passed as part of H.R. 1, the One Big Beautiful Bill Act, on July 4th of 2025. And it established a one-time 5-year Rural Health Transformation Fund of $50 billion that would go across 5 federal fiscal years. And that would distribute $10 billion annually to all 50 states, half of it equally. So $5 billion in each year goes equally to all states, and the other $5 billion per year is based on a pretty complex scoring factor and on the competitive applications that states submitted. The guidance for this application came out in mid-September, and we submitted our proposal on November 4th, so lightning fast timeline for developing a really incredibly complicated grant. If you could go back. Yeah, sorry, it's okay. Each state was asked to apply for $200 million a year, so $1 billion across the 5-year period, and I think we came within a few dollars of that. And it's one application for all 5 years of funding, although, as noted, things can change over the next 5 years. We had been anticipating, well, we prepared for a range of scenarios in terms of how much funding we would get. Some national organizations had estimated that we might get around $150 million. We were very, very pleased to learn at the very end of the year that we would get just over $193 million for the first federal fiscal year, which was great. All 50 states did receive awards. They averaged out to $200 million. I think the highest was in the range of probably close to $300 million a year. Next slide. So in addition to the data about rural health access and workforce needs and health that went into this, we really prioritized public engagement in the development of the application. So we had a website with a public comment, and we got more than 350 responses that came from almost every county in the state. We also had 50+ meetings with external partners representing many, many different stakeholders and communities that would be part of or could be part of the grant. We met with legislative leads and with the congressional delegation and their staff. We worked really closely with organizations that represent the types of entities that CMS described as eligible to receive funds as part of the RHTP. So we worked closely with the Hospital Association, the Association of Community Health Centers, the Association of Community Mental Health Programs, as well as Association of Minnesota Counties, LPHA, and others. We were really happy to have a strong set of letters of support when we submitted our application. We got letters from all 4, I think, of the legislative caucuses, from the GOP congressional delegation, which represent the rural areas of the state, from Senators Smith and Klobuchar, MHA, well, you can read the others, and the large health systems that represent rural areas, along with other professional organizations and the Office of Emergency Medical Services. So it was a really strong and bipartisan show of support, and I think that really helped us with CMS. I'll just quickly go through 2 more slides, and then I'll turn it over to Ms. Radosevich. CMS laid out 5 different domains of activity that states could apply for. They aligned quite well with the public comment that we heard about rural health needs and priorities. And based on that public input and on the CMS priorities, we laid out 5 goals in our grant. And you will see that these really guide all of the activities that we will be funding over the 5 years. I won't read all of the words, but I will just say generally, number 1 focuses on how we can improve outcomes for certain chronic conditions in rural areas. Number 2 is about workforce. We know that there are many, many challenges with building and recruiting and maintaining a healthcare workforce at all levels in rural areas. So we want to really build on some of the strong work that is already happening and programs that the legislature has already supported here in Minnesota to expand the healthcare workforce. We want to expand healthcare access in rural communities through mobile, telehealth, community-based care, other things that bring critical services close to people in their communities, because we know that distance and travel time is a challenge in a lot of rural communities. We want to strengthen the delivery of those services through enabling partnerships between provider organizations, whether that's learning communities, echo networks, telehealth connections that bring rural providers together with urban providers who are more experienced in certain specialty areas or rare conditions. And we want to strengthen and stabilize rural provider finances through smart and strategic investments in technology and data infrastructure to help them be more financially sustainable. So after the next slide, I will turn it over to Ms. Radosevich. So the 5 sort of buckets of work, the 5 initiatives that are funded align really closely with those goals. Technology is not a goal in and of itself, but technology is something that is really woven throughout all 5 of the initiatives, and is something that we see as a way we can be supporting providers in making some of those initial investments in whether that's remote monitoring, telehealth, software to manage kind of their revenue cycle or billing processes. We think it can help them across all 5 initiatives. And with that, I will turn it over to Ms. Radosevich, who will talk more about the activities and about the implementation of the grant.
Welcome to the committee. If you can state your name for the record and you can begin.
Thank you. I'm Zora Radosevich. I'm the Director of the Office of Rural Health and Primary Care in the Health Department. So as I go through the slides, the initiatives, just want to note, there's a note on each one that shows where in the narrative you can find more information, and I'll hit some of the highlights. But preventative care and chronic disease management were 2 clear priorities of our external partners as well as ourselves, and are reiterated. They were reiterated through all of our public comments and that engagement process. So we're using this initiative to take a comprehensive approach to addressing risk factors to move the needle on chronic disease management and prevention. And we're helping to ensure that rural Minnesotans are able to access community-based care. So some of the activities in this initiative are to improve and increase chronic disease screening and education, referral, and follow-up, and to promote and expand chronic disease self-management in clinics and communities. So workforce was another crucial priority for the rural communities that we worked with. Through our work with stakeholders, we recognize that it's important to start young in introducing students to healthcare careers everywhere, but particularly in rural areas. And to that end, we have the first two bullet points that are introducing more high school students to healthcare careers through scrub camps and various other initiatives, and developing more allied health pathways through earn and learn and apprenticeship programs, building on some of the work that's already been supported. And we wanted to build on our goal of increasing opportunities for clinical training in rural areas that builds on the research that shows that people do tend to work where they train. And so we wanted to increase the number of training areas in rural communities. And so we're expanding the Rural Clinical Rotations Program that was funded by the legislature. And we'll be developing more rural residency programs for physicians and advanced practice providers throughout the state. So our third initiative to sustain access to services to keep care closer to home is looking at expanding models that integrate frontline staff into care settings so that people can access care, again, closer to home. And part of the initiative will be providing technical assistance to organizations who want to make more of an investment in that frontline workforce. And we'll be doing other initiatives are included to expand like access to mental health training and post-pension programs, and then to expand telehealth access points in rural communities in places like pharmacies or schools or public health offices. So we know that healthcare services need to address the whole person, especially in those communities where the number and the type of healthcare services may be more limited. And we also wanted to focus on building for long-term sustainability. So our fourth initiative is looking at creating regional care models, again, that improve whole person health. And some of the activities within this initiative are to pilot a system that will compensate ambulance services for the 911 responses that result in patient contact but don't require transport to an emergency department. And that will be a 5-year study where we will be funding those entities and we'll be providing information to the legislature and others to learn how that is working and what is working well. We are supporting the initiative of building a children's mental health initiative patterned after the adult mental health initiatives that's working throughout the state. The funds will be used to develop new mental health urgent care centers and to provide bridge grants to plan for service line sustainability in OB to meet the population needs in rural communities. We'll also be expanding and building on the rural obstetrics high-fidelity simulation training that we've partnered with Community Memorial Hospital in Cloquet. And then because primary care providers, and that's one of the slides that is earlier in the presentation we didn't talk about, but the primary care providers tend to be that first line to specialty care often in rural communities. And so we are using the funds to support 2 ECHO programs, one focusing on maternal care from prenatal through delivery and postpartum care, and also one to connect rural primary care providers with mental health specialists. In our 5th initiative, we heard strongly from rural providers about the challenges they face in maintaining financial viability. And so this initiative is supporting funding for the acquisition of data management software that will boost capacity and capabilities for internal data management and their utilization needs. It will also be providing funding for rural care providers to leverage a range of AI applications to improve efficiency of their clinical operations and to increase the capacity of their clinical staff to work at the top of their license. And then other activities within that initiative would support funding for cybersecurity and revenue cycle management. So next we'll talk briefly about our implementation activities and planning. Since receiving word in late December, we have been working to get the program going, stand it up, and be able to disseminate funds. All of our funds are currently restricted. We had submitted a revised budget, as all states did, that weren't funded exactly at the $200 million level. And CMS has been reviewing that and responding, and we anticipate hearing fairly soon. But until that happens, all of our funds are restricted and we're not able to move forward with the program. When it does, there will be restrictions on how funds can be spent. There are some unallowable uses. One that was very clearly made to us is that the Rural Health Transformation Funds can't be used to offset Medicaid losses, and there are other restrictions that have been put in place for those funds. The funds that when they're released for this first year, will be able to be spent through September of 2027. And for every year going forward, the budget period will be 2 years, but this year, because the federal fiscal year runs October to September, we won't have those funds available. That first year has a really quick turnaround and timeline, and we'll talk a little bit more about that. And then the other restriction is on administrative costs. So administrative costs are restricted to 10% of the overall grant, and that includes the cost of running the program, administration within the department and our partners, but also all of the subrecipients. So all of the administrative costs are held within that 10%. And so that will be a factor that we'll be including in all of the grants that we'll be awarding. So we will continue to have touch points with CMS. It is a collaborative agreement, and so we will be working closely with them. We have met our Office of Rural Health and Primary Care we have a newly assigned project officer. CMS is ramping up to administer the program as well. We will be meeting with our project officer approximately twice a month going forward. All of the lead staff on this project are required to attend an in-person training with CMS in Baltimore in March. And then CMS will be making site visits to every state starting in April of 2026 for 2-day visits to take a look at what's happening, how the funds are being used, and what's happening in the state. Our first report will be due in August of 2026, which does speak to that really short timeline, and we'll talk a little bit about that with metrics that we will be having to report that early in the process, and then following that first year report, we'll be reporting quarterly to CMS. Continued funding is based on demonstrating that satisfactory progress. We will need to show progress on implementing the initiatives that have been outlined in our application. We will need to adhere closely to our implementation plan, and we will need to report on the metrics that we had outlined in our application. So some of the metrics, we can dive a little bit deeper in them, but we'll keep it at a fairly high level. But we will be required to report progress on our goals. So in developing our metrics, we worked with the MMB's results team. We consulted with providers wherever possible because we're trying to make sure that because of the quick turnaround and the need for a lot of data, we're trying to make sure that the metrics that need to be reported are as easy to pull together, and we will be working with our grantees and providing technical assistance to make sure that they are able to do the reporting. So the first year, we do anticipate that most of our reporting will be on progress measures, and then we will be moving more into the outcome measures that we listed in our application. But as most CMS and all others recognize, those results and the outcomes won't be as apparent immediately. So the funds because of that first year being so short, in terms of the mechanics of the funding, we knew that we would have less time for funding, and we wanted to be able to move as quickly as possible. So our year one focuses on that efficient dissemination of funding to hospitals, rural hospitals, FQHCs, the rural FQHCs, certified community behavioral health clinics, community mental health clinics, and tribal nations. And there will be some competitive funding available as well, but our first effort was to get the funds out to those with an allotted amount of funds. So this first year, this slide roughly calculates the allotted shares for the first year of funding. So you can see that about 70% of funds will be made available to rural hospitals, and then 5% for FQHCs, some for community mental health clinics, CCBHCs, and tribes. And then we anticipate having competitive opportunities for about 7% of the funds this first year, and using about 7% to scale up some of those programs that currently exist, but we will be able to do more with the RHTP funds to enhance those programs. Okay, this is just a map that shows like where all around the state those rural hospitals and community mental health clinics and FQHCs are. And as we noted earlier, the Rural Health Transformation grants, as with all grants issued by MDH, require thorough reporting of activities, documentation of how funds are spent, and they definitely need to show that the funds are being used only for allowable activities. As part of our application, we did have to demonstrate our strong internal processes for validating information that subgrantees submit, and that we have safeguards in place to identify issues and seek clarification to ensure accountability. We are very aware of the importance of meeting all federal requirements as well as state requirements, and our implementation plan accounts for that. We will be providing, as I mentioned earlier, ongoing technical assistance for grantees from our grant managers, from the evaluation team, and from content experts. We will be conducting insight monitoring visits and continuing to work closely with grantees on metrics and evaluation.
And I'm sorry to interrupt. I think the rest of the presentation is
Last slide.
That's it. That's
Explain it.
our last slide. So
Okay.
thank you very much.
And I just want to to allow just a couple minutes for questions, and then we need to move to the next presentation. Are there members, do you have any questions about? Senator Kupek.
Thank you, Madam Chair. Actually, I'm going to go to something that was in the beginning of all the maps and data that you, on the telehealth use. I found it interesting that rural Minnesotans had lower utilization of both phone and video visits. And when I look over at the chart of do you have reliable internet enough for a video visit, it's not really that much difference than our urban neighbors. Obviously, I know being on the broadband committee that there are places we're still trying to get that too, but I was always, under the impression, Senator Rutke and I have worked on bills on telehealth because we think it's really good for rural areas, but I'm just a little surprised that the utilization is not higher.
Madam Chair, Senator Kupek, it definitely has been increasing, and we do have some other reports that we could pull information from to show that, but it does lag the metro area.
One follow-up, I guess.
Senator Cooper.
So, I mean, is there anything else we can do to make sure we're increasing that usage or making it more available? Is there some legislative magic prescription?
Ms.
Madam Chair,
Radozovic.
Senator Kupek, I don't know that. But some of the things that will be funded through this program will allow for telehealth access closer to your community. So sometimes if you don't have access at your home, but you could go to the school or to the pharmacy and have access there, you could have those visits. And so we'll be looking at some of those issues. And then the other would be developing that comfort with using it. And I think frontline worker, that aspect will also be helpful in getting people comfortable with, with that technology as efforts continue to be made across the state really to reach that last mile of broadband service.
Well, thank you very much for the presentation. I think, members, if you have any questions about the specific initiatives, I guess it will be helpful if we know kind of when you receive the permission to go forward with the next steps and allocating the funding. And I would like to talk to you some more about that, how that's going to work as you go forward. But thank you for coming today.
Yeah,
I appreciate it.
Thank you.
And now we're going to move to a presentation by Hennepin County. We have testifiers Angela Conley, Dr. Megan Walsh, and Dr. Nathaniel Scott. If you could come to the table, or Senator Mann.
Thank you, Madam Chair. I just think it's important for us to just put into perspective that transformation program, the Rural Health Transformation Program. According to a fiscal analysis, our rural hospitals are going to lose $137 billion over 10 years. And this program is going to give hospitals back $50 billion. So we are talking about what we're going to do with just a little over a third of our original intended budget. And so I don't want us to believe that this program is this revolutionary thing that's fixing anything. It's not. It's, again, the federal government decimating our public health and healthcare infrastructure and then throwing us back a little tiny bit and saying you should be thankful for what we're giving you.
Thank you. And I was going to add a similar comment. One study I've read from Harvard, Chan Public Health School, the fund, the Rural Health Transformation Program Fund, is going to make up less than 40% of the estimated loss of federal Medicaid funding. It's truly not going to address the strain that's going to be felt on rural hospitals. And then as a transition to what we're about to hear, it does not address urban hospitals in any way. So they are left with the full brunt of the loss of the Medicaid funding with really no supplemental program like we just heard about. So welcome to the committee, Ms. Conley, and if you could state your name for the record and then begin your testimony.
Thank you. Good morning, Madam Chair and members of the committee. My name is Angela Conley, and I am the Hennepin County Commissioner for the 4th District. I want to thank you for having us this morning to provide a financial update on Hennepin healthcare system, including the flagship hospital, Hennepin County Medical Center, as well as to give some of the incredible providers a chance to share the impact of their work. Hennepin Healthcare is a nationally recognized Level 1 adult and pediatric trauma center, a teaching hospital, and the largest Medicaid provider system in Minnesota. This hospital is also very close to my heart. It's where 2 of my 4 children were born, and it's where I received care after surviving a heart attack in 2023. Every year, they treat tens of thousands of patients from outside of Hennepin County, from greater Minnesota, neighboring tribal nations, and even bordering states like Wisconsin, Iowa, and the Dakotas. As you'll hear from some of today's testifiers, their impact is truly felt in every corner of our state. Today, I'll provide an overview of the hospital's current financial position, as well as what it's facing the hospital over the next 10 years as H.R. 1 is fully implemented. As many of you know and have heard in the news, Hennepin healthcare system is facing significant financial challenges today, and this is due to a number of factors. The Change Healthcare Security event last year, as well as the dissolution of UCare this year, are both significant factors that have hurt the hospital's cash flow position. Prior to its dissolution, UCare was our biggest, HHS's biggest payer, healthcare payer. The end of the public health emergency in 2023 meant the end of presumptive eligibility for Medicaid, meaning many people lost their insurance coverage through their need for healthcare, though their need for healthcare continued. Medicaid is the hospital's biggest payer, so for people to lose their Medicaid coverage really was detrimental to the hospital's finances. We've seen a 5-year increase in uncompensated care. In 2020, it was $40 million, and in 2024, they saw $104 million in uncompensated care. About 24% of those costs come from outside of Hennepin County. Hennepin County currently is levying $38 million per year in property taxes to mitigate these costs. That's up from $28 million just a few years ago. And there are, of course, other factors like lack of adequate reimbursement, increased staffing costs, delays to discharge that create backups, and inflation that places a detrimental financial strain on the healthcare system itself. Additionally, the payer landscape continues to deteriorate due to loss of ACA subsidies and Minnesota Care eligibility changes. So today, the hospital finds itself with a need to immediately stabilize its operations. This includes finding $50 million in savings this quarter. The reason Hennepin Healthcare System is open today is because Hennepin County is able to act as a temporary financial backstop for the hospital through a line of credit, essentially acting as overdraft protection for the hospital. However troubling the short-term financial concerns are, they pale in comparison to the impact H.R. 1 will have on the hospital. HHS is set to lose an estimated $1.7 billion with a B over the next 10 years. $1.1 billion of that is the decline in directed payments, and the remainder is due to estimated increases in uncompensated care from individuals who qualify for Medicaid. But will get disenrolled due to the added hoops and eligibility requirements put in place in H.R. 1. Hennepin County cannot afford to absorb those costs, nor can we increase our property tax levy enough to even cover those costs. Without revenue to replace the ongoing losses, the hospital will not remain open. Madam Chair, in closing, I think I would be remiss if I did not call out the fact that despite the stress of the pandemic, despite the stress caused by recent federal government actions, which has had a significant impact on the health system, both the workers and the residents who have delayed receiving care. And despite the disinvestment in healthcare at the federal level, the employees of HHS continue to show up, continue to work with passion. They continue to provide work with dignity and with care for their patients and the important work that they do as a safety net hospital. With that, I would like to turn it over to Dr. Walsh with Hennepin Healthcare System.
Thank you, and welcome to the committee, Dr. Walsh. And if you can state your name for the record and begin your testimony.
Thank you, Madam Chair and members of the committee. For the record, I'm Dr. Megan Walsh, and I serve as the Chief Academic and Research Officer and President of the Medical Staff at Hennepin Healthcare. I'm here to share some insights about how our teaching hospital helps train the future healthcare workforce in Minnesota and how our research drives innovation and statewide impact. First, I'd like to ask you to do one simple thing. The next time you see your primary care doctor, your cardiologist, your child's pediatrician, your surgeon, ask them, where'd you do your residency? Where'd you do your fellowship? Where were your rotations in medical school? There's a strong chance that the answer will be at a Minnesota teaching hospital, and it's quite likely that it was Hennepin Healthcare. I'm here to share why sustained support and investment in our teaching hospital is critical. This is not just an urban issue. This is a matter of statewide workforce strategy, and without us, critical research and education that Minnesota depends on are at risk. Hennepin alone operates 22 accredited residency and fellowship programs. This is wide-ranging, spanning dentistry, primary care, emergency medicine, general surgery, cardiology, and more. We are also an essential partner to the University of Minnesota, training an additional 40 specialties per year. We train a third of all of the residents and fellows in Minnesota, but also 60% of the medical students, largely from the University of Minnesota, come to Hennepin for rotations. We don't just train, we also retain. 70% of our graduates last year in 2025 remained in Minnesota for practice. Over the last decade, 346 of our physician graduates have chosen to practice in Minnesota. 64 practicing in greater Minnesota communities, 11 of those are surgeons. That matters because right now, over a third of our rural providers plan to retire in 5 years. By 2030, 1/4 of rural Minnesotans will be over the age of 65. 80% of physicians practice in metro areas, while only 4% serve isolated rural towns. That is why in 2025, we launched what may be the only partnership of its kind in the nation with Sanford Bemidji Health. We send residents from a myriad of our programs to Bemidji for 1-month rotations. Emergency medicine started, psychiatry residents came next. Are you aware that there are only 2 child and adolescent psychiatrists in the northern third of Minnesota? That partnership expanded now to internal medicine, surgery, and family medicine. We are sending residents to Bemidji every single month. This isn't a short-term staffing patch. This is a pipeline strategy. It changes how young physicians see rural medicine as a calling and a career. If you see it, you can be it. Because when rural hospitals close, communities decline. When surgeons retire without replacement, trauma care disappears. When psychiatry is unavailable, emergency departments become holding units. Investment in teaching hospitals directly stabilizes rural Minnesota. But research at Hennepin Healthcare Research Institute also is leading initiatives that reach the entire state. We lead statewide data efforts through the Minnesota EHR Consortium to produce data that improves policy and practice in Minnesota. This data is now used by nearly every county department in the state. We implement and evaluate statewide efforts to expand integrated behavioral health care in both urban and rural areas in Minnesota. And we lead national data efforts focused on kidney transplant that guides fair allocation for organ donation. We lead a regional addiction research center that has participated in the largest studies in the nation to identify ways to effectively treat substance use. Our teaching hospital is a statewide impact as a workforce engine. If you represent a farming district, a lake community, a small town hospital, this matters to you. If you want trauma surgeons in northern Minnesota, if you want psychiatrists in greater Minnesota, if you want addiction treatment available outside the metro, if you want your constituents to age in place, our role as a critical teaching hospital matters to all of us. Thanks.
Thank you. And now, Dr. Scott, please state your name for the record and you can begin.
Sure. Thank you, Madam Chair and members. My name is Nate Scott. I'm an emergency physician and the Vice President for Hospital and Acute Care at Hennepin Healthcare. To Dr. Walsh's earlier points, I'm also a proud graduate of the University of Minnesota Medical School, completed several of my clinic rotations at Hennepin Healthcare, and then subsequently completed my residency training there. Spent the entirety of my professional career there in service of our patients and our community. I'm going to talk a little bit today about the clinical impact of some of the work that we do. In Hennepin Healthcare, we are leaders in trauma care and serve as Minnesota's first and busiest Level 1 trauma center. For more than 35 years, Hennepin Healthcare has been verified by the American College of Surgeons as a Level 1 trauma center, the nation's highest designation. Our trauma center cares for 3,000 seriously injured children and adults every year. This includes, as Commissioner Conley said, patients from all over the state, bordering states and tribal nations. Whether it's a farmer from southern Minnesota injured in an accident, child from northern Minnesota requiring care at our burn center, or patients from rural Wisconsin requiring advanced stroke care, we are here for them because we have the expertise, the technology, the commitment to care for the most complex cases, and our outcomes reflect this excellence over the years. We care for people from communities all over the states on their worst days, and these are not just abstract patients. These are our families, these are our friends, these are our neighbors. We submitted a few patient stories to the committee to help illustrate some of the life-saving care that our teams provide every day. However, as you would imagine, there are many more that we could have shared. Additionally, Hennepin Healthcare is known internationally for the emergency and trauma research that we do, and this is innovation that spreads outward, not just helping improve care at our facility, but also around the state, around the country, and around the world. We play a vital role in emergency preparedness. We are ready to respond to the crises, the disasters, the trauma that upend our lives in terrible ways, including mass casualty events such as the Annunciation shooting last year, and infectious disease emergencies and outbreaks like COVID and many others. It goes without saying, but if we were no longer able to serve Minnesotans in the many ways that we do today, this would have a profound ripple effect on other health systems in Minnesota. There are very few other places that can provide the type of care that we do and at the scale and the quality with which we do it. There is only one other comprehensive burn center and no other hospitals that provide emergency hyperbaric medical care in the state. Our patients simply cannot be absorbed by other health systems. Additionally, many of you have become familiar with some of the other operational challenges we face with regards to discharge delays, and you may be aware of how strained health systems already are, as finding safe post-discharge placement settings that will continue to accept increasingly complex patients' needs is a major challenge we continue to face. And when we cannot discharge patients from the hospital, our hospital beds quickly reach their capacity. The emergency department backs up with boarding patients waiting for a bed. And this results in our hospital being unable to care for trauma and other patients due to capacity constraints. And this is not a challenge unique to us alone. I'm grateful for the opportunity to testify today and happy to answer any questions. Thank you for your time.
Thank you very much. And I believe we had a testifier that you thought, might be available, but she is working and doesn't look like she is available. And Krista Steele, and I think, Jessica, are you planning to read? Can you read the testimony for her? Yeah, that would be great. If you could come to the table and then if you can state your name for the record, and then you will be talking about Krista Steele and her family story. So.
Madam Chair and members, yes, thank you. My name is Jessica Oaxaca. I'm the Advocacy Engagement Manager at Hennepin Healthcare, and Krista is actually on shift in the emergency department right now where she works, so I will be sharing her and her daughter's story. And I will just read it directly. Madam Chair and members, my name is Krista Steele. I am a nurse by trade practicing at a hospital in northern Minnesota, and I am here today to share how Hennepin Healthcare cared for my daughter and made a lasting difference for my family. On February 15th, 2018, my family was living in Princeton when my daughter Luna, who was 20 years old, sustained partial thickness burns to both of her hands after briefly touching a glass fireplace. I was 21 years old at the time, a single mother to Luna and my 4-month-old daughter, Lily. I had no medical background and no understanding of what was happening. As the blisters began to rapidly form on her hands, I was terrified. We were seen at a local emergency department and then transferred to HCMC for specialized burn care with plans for admission to the burn unit. By the time we arrived, nearly 12 hours had passed since I had breastfed my 4-month-old. I was physically exhausted, emotionally overwhelmed, and completely devastated watching my toddler in pain. I felt helpless and hopeless. From the moment we entered the ER at HCMC and throughout our admission to the burn unit, the medical professionals at HCMC demonstrated exceptional clinical skill and extraordinary compassion and awareness of the entire family. Without hesitation or prompting, they ensured I had access to a breast pump and even provided a mini refrigerator to safely store milk for my other daughter. They recognized that while Luna was the patient, I was also a mother in crisis, trying to care for 2 babies under unimaginable stress. They went far beyond routine care. They provided reassurance, education, dignity, and support during one of the most traumatic nights of my life. Their calm confidence, empathy, and professionalism carried me through the moment when I felt I truly might collapse from emotional distress. Today, Luna is 9. She is in her 5th year of competition dance and loves art. The doctors, who were very worried about contractures in her hands from the burns that she sustained at a young age, so the fact that she ended up with no contractures and loves art and dance is simply amazing. Because of the care we received at HCMC, I was inspired to pursue nursing. I became an LPN in 2021, an RN in 2022, earned my BSN in 2024, and completed my Master of Science in Nursing and Public Health Nursing this January. Their example of compassionate, family-centered expert care is something I carry into every single patient encounter. As I progressed in my career, beginning as a new nurse in a rural critical access emergency department, and later managing the stroke and trauma program, I gained firsthand understanding of the pace, pressure, emotional intensity, and competing demands that ER and critical care nurses face every shift. Knowing now what I didn't know then makes their compassion even more remarkable. Despite the trials, high acuity, and constant demands of emergency and burn care, they consistently provided patient-centered, passionate, and deeply human care. That level of presence is not accidental. It is exceptional. The way they treated me and my children, not just clinically but humanly, changed the direction of our lives. I will forever be grateful for the care the healthcare professionals at Hennepin Healthcare provided my daughter with, and for the quiet but powerful way they inspired my own career in nursing. Thank you.
Thank you for providing that. That's really, really good to know about some of what's actually happened to some families and how the team works together to serve them. Before we go to member questions, I would like to ask if you, Ms. Conley, or if someone else with you, I think you were bringing some other members of the Hennepin County team. I appreciate your going through kind of the financial situation, and you alluded to the fact that, or you stated that you are making difficult budget decisions right now because there's money or deficit that you need to resolve. And I would like either you or if someone else from your team could really share with us, because it's been reported in the media, about what are the specific changes that you've made to attempt to realize the cuts that you need to make in the first quarter.
Certainly. Thank you, Madam Chair. I'll ask Jill Matthews from our office. Audi's coming up right now.
Okay. I think that, we can understand at a high level how the different federal actions are affecting you, and I can see over time, the significant impact of that. But you are dealing with significant challenges right now this year, and that will have an impact on, the hospital right now. So if you could talk about that, and please, if you could state your name for the record, and then please answer the question.
Madam Chair, committee members, my name is Abdurrahman Abdi. I'm the Chief Financial Officer for Hennepin Healthcare. I've been in my role for less than a month right now. And so to better answer your question regarding our financial position, we are projecting anywhere between $40 to $50 million of loss, operating loss this year. A big part of that is really driven by some of the stuff that Commissioner Conley talked about related to inflation increases, low reimbursement, and the fact that we're operating at a negative cash position. And so the county has been very helpful in terms of supporting the hospital. We've taken some initiatives. We have identified $50 million reductions. Part of that includes reducing programs, reducing staff. We also have a plan to do further reductions. We've identified roughly around $150 million this year to be able to reduce from our operating costs so that we can have enough to be able to sustain the health system that our community needs.
And with those reductions, is that, so you said there's been 50 million identified, or I want to use the right word, but you said 50 million, and then you also said that over the year, the rest of the year, another 150 million, is that correct?
150 million, a total of 200 million initiatives, reductions that we're considering for 2026.
And if you, will those, are those taking into consideration what might occur within legislative actions, or is that external to just the planning that you need to do for this year?
Just the planning that we need to do based on our current financial performance. Obviously, there is the HR1, which is going to have a significant impact on the organization as we go into 2027 and beyond. Our directed payments, which is a critical component of our financial model, is going to be further reduced by HR1. We estimate that to be worth about $1.1 billion. And then disenrollment of Medicaid changes will have another $600 million, so a total of $1.7 billion within the next 10 years. So that does not even account based on the current financial performance that we're facing. So this would be in addition to that.
Okay. Thank you. And I believe Senator Abler has a question.
Yeah, thank you. And I appreciate this presentation. And I think we, the two doctors testified and, about the burns and, the testimony, pretty compelling. I think everybody agrees that we really need to have you there. And so how do we get there? I just have a couple of math questions. I don't know who can answer them, but just to understand. We've talked about, and there's two numbers I just want to clarify. So the discussion of uncompensated care, is that based upon the billing or medical assistance or Medicare rate reimbursement? When you say it's $100 million now, just do you know the answer to that?
That's the total amount that people who are receiving care at our hospital who are not covered by insurance, so we don't receive payment for them.
Right.
So it could include a lot.
Yeah, and so I mean, this is a decade of discussion about uncompensated care. So the number you're using to decide the loss, is that based upon the retail price?
That's our net revenue. So that's the amount that we expect to receive for the services that we're providing to those patients.
Well, I don't want to badger you, but nobody gets, except in maybe auto cases, you get paid 100% of what you bill. In Medicaid, you get 40% or something. And so if I'm an uncompensated care, I don't want to spend too much on this part, but so if I'm an uncompensated care patient, I have a $100 bill for something. Do you count that as $100 that I'm not paying, or as the $40 I would have got paid if I was a Medicaid card?
It'd be the $40, not the $100. So you're
that's
correct.
Helpful. I just want
in terms of our payment, we collect about 40% of whatever we bill. So the charge, as you noted, committee member, the charges are different than the net revenue. And so I believe the number that we have in front of you is what we would expect to collect from those patients.
All right, well, I appreciate it. That's helpful
Senator
to know.
Abler.
That's very helpful to know, because this is, the audience members, this has been a long discussion. And then the 1.1 billion from the HR1, the directed payments, is that money that you would have gotten, or is that part of the money that was disallowed by changes that didn't do some of the directed payments that was passed last year? Do you know that?
Because there'd be changes to directed payments, that's money that we would have received if we stayed with the current directed payment methodology that we have. Because there's going to be changes to directed payments, committee member, we're not going to be receiving that money. And so the 1.2 is a combination of a $10 million estimate based on what we're getting paid today versus what we'll get paid in the future.
Senator Abler, just so it is totally separate from, it's not related to the bill we passed last year.
It's not, I just wanted, and that's why I was waiting for an answer from MMB on that topic. So it's just helpful to know how deep the hole is, so.
Senator Abler, the Hennepin County had an existing directed payment program, and that's what this relates to.
Oh, thanks. Yeah, I haven't been briefed, nobody's visited me, but we have to find a way to help you stay there. And I appreciate the efforts you're making. And I think this is just a pure policy thing, and how are we going to do it to make it work. It's a unique model where you have the county backing it up, and you can't live on all that. So, but Madam Chair, I just want to remind us that some of the places we're at is because of state decisions as well. If you recall, in the 2023 conference committee, I tried to move $22 million from an unallocated pool, and my success was that Representative Liebling gavelled me down. So, and we had $3 billion in this committee in 2023 that we might have done something with the boarding issues. So, Madam Chair, so I think if there's some ways that we can look at what we've done in our committee here to help continue there as well. I know there's talk about about a sales tax and so on, but I'm committed to working with this and looking forward. But I think we're going to see more of this stuff I mentioned with the previous discussion with the Department of Health. We have offered, I didn't say this part, we've offered all kinds of things to all kinds of people. And in our generosity to serve individuals, we've enrolled more and more people in medical assistance and Minnesota care at rates that are unsustainable. And so that kindness is actually now coming back to bite us. And I want to thank Hennepin County's work for 75% of people are on those federal and state programs. So thank you, Madam Chair. I appreciate that.
Senator Edke.
Thank you, Madam Chair. And yeah, as it's been mentioned, the patient mix that you guys serve, being the largest MA provider in the state, we know what that does to your finances. And then you also mentioned that UCare was your biggest payer. We know the challenges going on right now with UCare, but when we look at the income losses that you've got on the books right now, are there non-payments from, in this case, UCare, the health plan, that is built into that? Or is this actual income losses for the services you provided? I just trying to find out if there's a core, if they're overlapping or if they're separate.
Committee member, this does not include any losses from UCare. The $40 to $50 million projection related to our operating income for 2026 is based on our current operations. It does not include UCare. We have already accounted UCare as part of our 2025 financials.
Senator Edke.
Thank you, Madam Chair, and thank you for the clarity, because it is important. You're dealing with some pretty big numbers to have to cover. And part of this, I guess, is for our Madam Chair and our committee. This is only one provider. We've got other providers in the metro, up in that part of the metro area, and across our state that are all struggling. They just happen to be the biggest, so they got big numbers. And I think we need to spend some time this year figuring out what we're going to do to work with these and try to help them, because we got to have them. We just heard about all the great services they provide, whether it's the teaching and the instruction, and when you talk about the residency, we listened to a couple doctors that they did their residency at the Hennepin County Medical Center and they stayed. Well, we talk about it in our rural areas. We want you to come out and do your residency in our small hospitals because we want you to stay. That's how important this all is. But this conversation needs to be more than just one and done, because they're in a serious position, but we've got others that are equally, they're losing big dollars, and we can't afford to lose a single one. So, Madam Chair, I hope that we can have at least another hearing just directed to the financial viability of our hospitals and what we can do to make sure that they're around for this year, next year, and for years to come, because you know, we can't change some of the things that are coming down the pipe to us, but we can sure work on what we can do here in Minnesota. And I think it's going to take some serious conversations. So thank you.
And I can assure you, Senator Radke, that we will definitely have more conversations about hospitals and financing and the impact of changes on hospitals. I think that you're right that, you know, we can't afford to lose more hospital services, you know, across the board, whether it's in greater Minnesota or in the metro area. I think what I intended by bringing this forward today is to highlight the sense of urgency about Hennepin Healthcare's current situation and the immediate need we have to recognize that this is something we need to address this session. And we need to discuss, because the absence of Hennepin County Medical Center will cause a huge strain on the rest of our metro hospitals, metro trauma care in regions, North Memorial. We know that the loss of this would be so significant to the whole metro area and the greater Minnesota, all of the people who depend on coming here for, you know, specialized care. So that's why I wanted to highlight it first. It hasn't been, you know, something that they've brought up to us today, but you know, just last week, the cost-cutting measures are going to include having fewer hospital beds at Hennepin County. And it looks like, you know, perhaps 100 beds will have to be taken offline. I mean, that's a huge number for that particular entity, and it's a huge impact to our community, you know, that relies on being able to send people to Hennepin County Medical Center. Ms. Connolly, and I'm sorry, I didn't get your last name.
Abdi.
Abdi, do you have any comments or that you wanted to make to any of the discussion?
Madam Chair, I just want to thank you for this opportunity to present today. We really value and appreciate what Hennepin Healthcare brings to the entire state. Without it, there is a statewide ripple effect that happens. And in addition to the, you know, Hennepin Healthcare closing, right? I don't want to see any hospital in this state close, because we have rural healthcare centers that, should they close, you have residents who would need to drive hours and hours for care, for clinical care. So I just appreciate the time that we were able to highlight those impacts today. Thank you.
Thank you very much, and I appreciate it. I think if we have more questions as we go forward about particular instances or particular financials, we'll definitely reach out. And I really appreciate your bringing your team here with you today. So thank you very much.
Thank you.
Members, having no more business before us today, our meeting is adjourned.